Okay, so I have an interesting topic, and I thought about this a little bit about how do I really go about talking about the evolution of physiological pacing. It can be a talk for a full day because we're talking about the entire history of how we got here, essentially. Oh, so this doesn't advance slides. All right, so those are my disclosures, none of which should be relevant for this talk. So what we're going to review really is how did we get here? You know, how did we get to this point where physiological pacing has become, something that every one of us wants to learn and perform. We'll talk about Hispano Pacing primarily for how does this prevent adverse outcomes? How does this potentially reverse some of the clinical outcomes? And what are the challenges that we have today? That will then lead us to left bundle branch pacing. And then finally, we'll talk about where do we really go from here? What does the future hold for us, which may be something we still don't know. So how did we get here? We're all aware that conventional RV apical pacing results in structural changes within the ventricles, and this in turn then leads to adverse clinical outcomes. And those include increasing incidence of atrial fibrillation, increasing incidence of pacing-induced cardiomyopathy, heart failure, and an associated increase in mortality. All of this information comes from studies such as the MOST sub-study, the DAVID trial originally, and many other studies that have been more recently performed. This was just a compilation of all these studies that we've looked at, and if you look at these studies that talk about pacing-induced cardiomyopathy, you see that the range of pacing-induced cardiomyopathy in all of these studies varies from as low as 10% to as high as 60%. And that's variable depending on the population that's being studied. Are you studying sinus node dysfunction patients that are pacing very little? Are you studying patients with complete AV block that are pacing 100% of the time? And how do you define pacing-induced cardiomyopathy? Because some of these studies actually define pacing-induced cardiomyopathy as a drop in EF to less than 50%, while there are others that define it as a drop in EF to 40% or lower. So all of these definitions and patient selection determine what is the incidence of pacing-induced cardiomyopathy that you see in these studies. So as we talked about, the DAVID trial was the first one. This was ICD patient population, where they programmed these patients to either dual chamber pacing, which back in the day, this was back in 2002, they used to consider dual chamber pacing was the physiological pacing, which we now know it isn't. And they programmed them to either a VVI backup mode at 40 beats per minute or dual chamber pacing mode at 70 beats per minute. And what they found was that there were poorer outcomes with time to death or first hospitalization for heart failure in those patients that were paced in the ventricle. Similarly, the MOST or the mode selection trial really looked at pacemaker cohort of patients for sinus node dysfunction. What they did was they took 2010 patients and they divided them into saying, all right, we're going to pace you in a dual chamber mode with a longer AV delay, or we're going to pace your RV alone. And clearly those patients that were paced in the right ventricle alone did poorly. This was a sub-study from that same mode selection trial, which also demonstrated that with the increasing burden of pacing in the ventricles, you can see the higher burden in the bottom. This was 40% or more or less. You can see patients that were paced 40% or more in the ventricle were likely to develop heart failure with a 2.6-fold higher incidence. This is the sub-study that actually, where our guidelines talk about 40% as the, that's the gold standard. If you're paced 40% or more in the ventricle, you could get a BIV. This is where it comes from. So 40% showed that the incidence of heart failure increased by 2.6-fold or higher. And again, if they were paced 80% or higher, then the incidence of heart failure increased even more. Similarly, we also saw that the incidence of atrial fibrillation increased with increasing burden of ventricular pacing. So that then led to, and there were a few other more recent studies that actually demonstrated that even 20% pacing burden might be enough to cause a high enough burden of pacing-induced cardiomyopathy. So that then led to the search for alternative sites. And so we started looking at non-apical pacing sites, which was pacing RV septum or RV outflow tract. And this is just a meta-analysis that looked at the non-apical pacing sites compared to the apical pacing sites. And what it really showed us was that if a patient has a low ejection fraction, 40, 45% or lower, then RV non-apical pacing might be better. But for those patients that have a normal EF to begin with, there was no significant benefit with RV non-apical pacing compared to RV apical pacing. So we were still, perplexed with what do we do for those patients that develop that pacing-induced cardiomyopathy, and so that led to looking at biventricular pacing as a potential option for that cohort of patients. So BLOCK-HF was the first study, and Curtis, New England Journal of Medicine, 2013, a US-based study that really looked at patients that had AV block, so their likelihood of pacing in the ventricle was higher, more than 40% anticipated pacing. They also included patients with a long PR interval, long first-degree AV block, where we know it may be difficult to program around with dual-chamber devices, and those patients that have had an EF less than 50%, because we know that patients that have a lower pre-implant LVEF are the most likely to develop a pacing-induced myopathy. And what they found was, looking at a pre-specified endpoint of heart failure, mortality, and LV end-systolic stroke volume, biventricular pacing in orange did better than RV pacing alone. Okay? So BLOCK-HF was a positive trial for biventricular pacing. But then, at the same time, the other trial that was ongoing that no one ever talks about and has not been published to date. This is important. As we look at science, we need to know what the data tells us. So BioPace was a simultaneous trial that was ongoing in Europe, outside the US study, with many more patients. You look at the number of patients in this study, 1,810. You look at the number of patients in BLOCK-HF, it was close to 600 and something. So 1,810 patients with a normal EF or a low EF, 571 patients had a low EF in this cohort. And what they found was bi-V pacing or RV pacing, there was no difference in hard endpoints of mortality or heart failure hospitalization. This study was presented at AHA, I believe, ESC in 2014, and has not been published to date. This was an Abbott-sponsored study. Okay, this is an important study that needs to be published because this data is important, right? This data actually tells us bi-V pacing may not work for this cohort of patients. But the current guidelines now use BLOCK-HF and include that cohort of patients as an indication for bi-V pacing. What happened to BioPace? No one wants to talk about it. So that then brought us to conduction system pacing, and the first thing that we actually started performing was Hispano pacing. So let's talk a little bit about the history. So what is permanent Hispano pacing? It is implantation of a pacing lead at the bundle of His, distal to a site of anticipated disease. This is the key point. Unless you do your due diligence to find that location of disease and place that lead distal to that site of disease, you're doing a disservice to your patient. Okay? So that's the most important aspect. Now, what are we trying to achieve? We're trying to preserve, in a patient that has a normal QRS, we're trying to preserve that normal QRS, or normalize. In a patient that has a bundle branch block, we're trying to normalize biventricular activation. So either to preserve biventricular activation or to normalize biventricular activation. And the hope is that this preservation of biventricular activation or normalization of biventricular activation would then prevent some of these adverse clinical outcomes that we've seen and maybe even correct some of the adverse outcomes that have already occurred. So let's see if that's even possible. So this is what it would look like. Here's just an example of a patient with a relatively normal QRS, right bundleoid, but a normal QRS duration with a very long PR interval. And you know that this patient, at least in the US, would end up getting a dual chamber pacemaker, also had AV Wenckebach and symptomatic, and is very likely to pace in the ventricle almost 100% of the time with a PR interval of more than 400 milliseconds. Okay? When you have a PR interval more than 330, 350 milliseconds, just realize no avoidance of ventricular pacing algorithm is going to avoid ventricular pacing in these patients, okay? So this is a classic example of someone that would end up pacing a lot in the ventricle, and this is what his bundle pacing would look like in this patient population. So this is an example of selective his bundle capture. And here's this is paced, and this is the intrinsic QRS overlaid on top of the paced QRS. So how did we get here? So we know that the initial recordings of his bundle were performed by Ben Sherlag in the dog model, in an open heart model with the dog, or a canine model in 1967. It was his group that then went on to performing recordings of the human his bundle using endovascular catheters. Subsequently, it was Dr. Narula in the 1970s that actually used multi-electrode catheters and recorded multiple his recordings in the human heart. It was also him and El Sharif that later on, in 1977 and 78, went on to first describing the theory of longitudinal dissociation within the his bundle, and we'll talk about that in a moment. So the first permanent pacing at the bundle of his was actually performed by Dr. Deshmukh. Again, we should be proud. There's a lot of brown people in EP that have done a lot of good work in this field. So Dr. Deshmukh works up in northern Pennsylvania. In fact, when I was interviewing for cardiology fellowship is when I met him for the first time, way back in 2008, 2009. And he published this paper back in 2000. So he did these cases in 97, 98. He used extendable retractable leads with pre-shaped stylets with a mapping catheter from the groin to know fluoroscopically where the his bundle is, and then he took these leads and tried to place them there and tried to achieve physiological pacing. Again, he took a very sick cohort of patients. These were all patients with a low EF, dilated cardiomyopathy, permanent atrial fibrillation, so oftentimes their atria are gigantic. And he was successful in 12 out of 18 patients, which was 65%. Not the highest success rate, but for the first experience, commendable. Again, these patients actually demonstrated a significant improvement in the EF from 20% to 30% on average, but there were also 2 lead dislodgements. So that became a little bit of a cautionary tale. Subsequently, there were multiple groups in Europe. There was Barba Picardo from Spain, there was Archetta from Italy, there was Zanin from Italy. All of these groups performed work on his bundle pacing in the early 2000s, 2006, 2007, 2010. So why are we here 2 decades later? We haven't really still gotten that further along this way. So why hadn't it gained popularity then, and why are we talking about this now? So back then, the success rates based on all of these studies were about 65 to 70%. So if you're going to spend 2 or 3 more hours doing a dual chamber pacemaker and get a success rate of 65, 70%, maybe not something that everyone's going to want to do. The other issues were that a lot of these studies would actually require putting a mapping catheter from the groin. In the US, for no dual chamber pacemakers do we actually put a mapping catheter from the groin. Okay, so it's not common practice. The other issue was also a lot of these studies then started reporting putting a backup RV pacing lead. So what's the purpose? You're actually putting in a bi-V device where the patient just needs dual chamber pacing. It's not something that's going to be a selling point. And then there was not a lot of data on the benefit of his bundle pacing over conventional RV apical pacing. The other thing that was also happening that I haven't put on this slide at the same time was a lot of money and a lot of effort in building the bi-V pacing platform. Okay, it was the early 2000s where biventricular pacing became the next big thing. And so no one was going to invest into this any further. So what's changed and why are we here talking about this? So newer tools and delivery systems. I should say one new delivery system and an old lead that Medtronic got lucky with. Okay, that's what happened. The success rate suddenly with his bundle pacing in our early reports were about 80%, and now we have success rates reported about 95 to 97% in experienced hands. We don't use any additional steps. We will not routinely put in a mapping catheter. Even if we choose to put one, we'll put it from the device pocket rather than getting a separate groin access for it. And Unless it's a rare circumstance, we do not recommend putting backup RV pacing leads in all of these dual chamber pacing systems. So we've moved away from a lot of that. Also, a lot of data has emerged over the course of the past decade on the benefit of Hispano pacing over conventional RV apical pacing. And again, like we talked about, there's limited data on the benefit of Hispano pacing for cardiac resynchronization. So that's why we're back here talking about this and how do we advance this field. So the tools, I think, one of the titles was talking about the tools that we have. So I'm just going to touch upon this. I have another talk that is dedicated towards how do we perform the implant, and we'll dive in a little bit deeper in that. But I just wanted to highlight some of the tools we already have and some that are about to come out within the next few months. Okay. So the go-to lead that we use at the present time, and the only reason we do this is because we have a lot of data with it. We only start using systems when we have a lot of data about safety, when we know what the potential issues can be. So with the 3830 Medtronic lead, we have the most amount of data. It's been used close to 8,000 or 10,000 times, and we know what the limitations are, we know what the positives are. It's a lumenless 4.1 French lead, and the advantage that it's for French, so it does not cause a lot of stress and strain on the helix when it's implanted at the his bundle. And because it's lumenless, it requires a delivery sheath. The other thing also with this lead is that it has an exposed helix. So it is not extendable, retractable, it's an exposed helix. And so you have to rotate the lead body to get a bite into the conduction system. The delivery sheath that you guys are all hopefully familiar with is the C315. It has two curves. The primary curve, which is septal, the secondary curve, which points it towards the RV. The other sheath that we have available in the US is the C304, which is now also becoming obsolete because Medtronic in May of 2019 at HRS came out with the new sheath that we helped them develop, which is essentially just a minor modification of the 304. It's you can actually rotate this sheath with this knob, and it can get up higher on the AV annulus, but it also now has the septal curve. The original 304 did not have the septal curve. The disadvantage of this sheath is it's a much larger caliber. It's 8.4 French, so it's like a CS delivery sheath, and it can also cause more trauma to the conduction system. So we're a little bit careful. I only use this as a backup if the 315 fails. And so I know it's not available in India right now. This is still not the go-to for a lot of us. So newer tools, Boston Scientific just came out with their set of dedicated HIS delivery catheters. These are, aside from Medtronic, which again, the 3830 was not designed for Hispano pacing. It was designed for pediatric implants. It was first released in 2004, 2005 for implantation in pediatric cases. They got lucky with it because it works very well for Hispano pacing. No company has a dedicated lead for conduction system pacing as of date, and it's going to be years before that becomes the case. Okay? So all of the newer, everyone wants to get into this race because everyone realizes that there is a lot of excitement about conduction system pacing. So Boston Scientific came out with their set of delivery sheets. They have a range of them with different shapes and curves and lengths, and they recommend using their Ingevity lead, which is an extendable, retractable lead for implantation at the his bundle. We have also tried to use the fine line, which is the sweet tip, as some people call it. It is closer to the 3830, but it does tend to get stuck much more in different parts as you're pulling the system back and forth. So we've tried to use the Ingevity more than the fine line. The other system that is about to come out is this Biotronic system. It is already available in some parts of Europe where they're doing some of their early work, and it should be coming out in the US by the end of the month, and I have some cases lined up with this. I actually helped them design these sheets. So again, this is a set of sheets, delivery sheets, to help implant their Solia lead, which is also an extendable, retractable lead at different parts of the conduction system. Again, I have to caution you. This is a word of caution for all of you who are interested in doing conduction system pacing. Please, please, please do not take an extendable, retractable lead and start pacing it at the his bundle or at the left bundle just yet, unless it is a non-dependent patient, unless it's a patient with sinus node dysfunction and you know they're not going to pace in the ventricle. We do not have any data on long-term performance of any of these leads. We are working closely with industry to do the studies so we understand how these leads perform. You have to realize these are bigger caliber leads, they're extendable, retractable helixes, their thresholds might increase much more, they might actually frankly dislodge. In fact, some of the early work, the work that Dr. Deshmukh study did, the work that Barbara Picardo study did, actually used extendable, retractable leads. Barbara Picardo did all their work in Spain with the 2088, the Tendro, the St. Jude Tendro. And that cohort of patients actually demonstrated a higher his bundle capture threshold, and they have never published any long-term data in terms of what happened to their thresholds and follow-up. So be very careful. You will be pressured by your industry counterparts that we have our delivery system now, so go do it. Please be careful. You do not want to have a bad outcome for your patient. So please do not do it in a patient that's dependent. Okay? That's just my word of caution. So yes, I'm showing you all these tools that are coming out, but I am not telling you that go and start using them right away. This is just some tweets. Deep, I wanted to highlight Deep is a fellow from here at M who's working with Rajiv, and they've done some work with the Biotronic delivery system, and also Sergio Richter has done some work with the Biotronic delivery system. In fact, Oasis actually recently posted a tweet on a patient where he did, with the Biotronic extendable retractable Solia lead, what we think might be a left bundle branch pacing. So again, not something I would recommend doing yet. We don't know what the long-term performance of this is going to look like. So again, when we do these cases, we actually use the PSA to look for your A, His, and V. And we'll talk about this more when we talk about how to do the implant. And then we also use our EP mapping system with filtered and unfiltered electrograms. And you can actually see a nice A, His, and V. The advantage of the unfiltered electrograms is you can actually see a His injury current corresponding with the His signal. We'll usually set it up where there's a set of injury cables going to the patient. That then goes into the EP pin box. And then from the pin box, you can actually slave it to the PSA. And then the most important tool, whether you're doing any form of conduction system pacing, whether it be his bundle pacing or left bundle branch pacing, the 12-lead ECG. Now, this was another thing that has evolved a lot. In the original descriptions of his bundle pacing, we used a lot of terms loosely, or we called it pure Hisian capture, para-Hisian capture, direct his bundle pacing. In our first paper, we called it direct his bundle pacing. And then over time, we realized that there are multiple people doing this, and everyone uses their own terminology, and we decided we need to come up with standardization. Standardization on how to report, standardization on how to perform, standardization on pulse widths. All of this needs to be standardized. How does the follow-up be standardized? So this was a consensus document we published in Heart Rhythm in 2017 with a series of experts, and we defined this as selective and non-selective his bundle pacing in patients with AV nodal disease and infranodal disease, and how that might differ slightly. So this is just a reference slide here. All right, so now let's look at the data. Fine, his bundle pacing looks good. We know that it can be done. The success rates have gone up, but does that really have an impact on how these patients do? So can this prevent some of those adverse events that we talked about with RV pacing? This is a table from a paper we published in Nature Reviews that summarizes all the data that is available on his bundle pacing for dual chamber systems. This was the first study we performed, and it was published in Heart Rhythm. This was when I was still a fellow with Dr. Vijay Raman. This was work done in 2010. And again, I'm highlighting. You always have to be aware. People can show you slides. I can make this look nice and pretty, but this is non-randomized, okay? Everything needs to be taken with a grain of salt. There are no randomized controlled trials to date on his bundle pacing except for 2. And both of those, the maximum number of patients are 40. Okay? So what we did here really was we took two different sites in the same health system. One site, everyone got Hispano Pacing attempted. The other site, everyone got RV pacing. And what we we found a success rate of 80% with Hispano Pacing. And we followed these patients, and we looked at those patients that were paced more than 40% of the ventricle. And what we found was that with Hispano Pacing, very small chance of developing heart failure, while those that were RV paced, a significant difference between RV pacing and Hispano Pacing when it came to incident heart failure hospitalizations. Again, the study was in no way powered to assess for mortality, but you can start seeing there's a little bit of separation of curves as you start following this cohort for a longer term. We then looked at their long-term follow-up, 5-year follow-up, and we published the long-term follow-up in 2017. We brought all of these patients back and performed serial echocardiograms. So this was their long-term follow-up. If you take all comers, whether they were implanted for sinus node dysfunction or AV block, you see that with Hispano Pacing, the baseline EF is in blue and follow-up is in red. You see that the EF remains stable, while with RV pacing, the EF declines. Now, if you were to take those patients that were truly paced in the ventricle with 40% or more burden, you see that the EF declines even more significantly in the RV pacing group, but does not change significantly with Hispano Pacing. So, at least as a cohort, there is no significant change in LVEF and follow-up. This was the largest series to date, which was presented as a late breaker at ACC in 2018. This was again Dr. Vijay Raman's group. And they took 332 patients with Hispano Pacing versus 433 patients with RV pacing. This was work that was done between 2013 and 2016. So 2 or 3 years of gaining experience with these implants. And you see that the success rate for Hispano Pacing actually went up to 92% in this study with a much larger cohort of patients. And again, similar results, pre-specified endpoints of heart failure hospitalization, mortality, or need for upgrade to a bi-IV pacing system. You can see that Hispano Pacing did better than RV pacing. If you took those patients that were paced 20% or more in the ventricle, that difference or the separation between the curves was even more significant. Now, we talked about how RV pacing increases the incidence of atrial fibrillation. This is work that we just finished and is going to be presented at Heart Rhythm this coming year, in May. So just wanted to give you a glimpse of this. This is new onset atrial fibrillation amongst patients with Hispano Pacing in blue versus RV pacing in red. And if you look at patients that were paced just 20% in the ventricle, look at the separation of the curves in the p-value. Okay, so Hispano Pacing not just prevents pacing-induced cardiomyopathy, but also decreases incident atrial fibrillation. So that was for prevention of some of the adverse outcomes that RV pacing can cause. What about reversal of some of the potential issues that have happened with RV pacing or that occur with cardiomyopathy? So here's a case to highlight that. This was a 75-year-old gentleman. He's actually one of our CICU nurses' dad. He went to Florida and had some sinus bradycardia, so they put in a dual chamber pacemaker. He also had some history of atrial fibrillation with a low burden. So he gets a pacemaker, and then his daughter reaches out to me and says, I really want him to follow up with you when he's back here in Chicago. So I said, sure. So surprisingly, you bring him in for a device check, and he's pacing 89% in the ventricle. It's like your device was implanted for sinus node dysfunction. Why are you pacing the ventricle? His PR interval was over 400 milliseconds. So we paced, I switched him to an AAI mode. I said, forget the ventricular lead, let's just make you AAIR. And he started having AV Wenckebach. That's the issue when a patient has sinus node dysfunction and you don't pay attention to the PR interval, or if a patient is elderly and you don't pace them at a faster rate to see if they start Wenckebaching at 80, 90 beats per minute. They're going to require ventricular pacing. So this is what happened with him. This in blue on top is his trend of ventricular pacing burden. In green is his ejection fraction. And in red is his AFib burden. So this was when he got his device implanted. His EF was 60%. His AFib burden was only 6% in follow-up. And I made all the changes, and he had AV Venkibox, so we had to program him with, I programmed him with VIP. This was a St. Jude device, so that we can avoid ventricular pacing, and he still paced 99%. And his EF started going to 50 to 55%. His AFib burden started increasing simultaneously, then it dropped further. And so his EF continued to decline, and his AFib burden continued to increase. So now what came first, the chicken or the egg? Was this AFib that was causing him to have tachycardia and worsening cardiomyopathy? Or was it pacing that was causing all of these issues? So we decided to control the AFib, put him on amio, hoping that that'll prevent AFib. He just couldn't tolerate it. So with the low EF, his renal function was borderline. We couldn't do Ticasin. So amio was the only option, and he couldn't tolerate amio. So then he said, can we do an AFib ablation? So we performed an AFib ablation on him. And after the AFib ablation, his EF still remained low. So we brought him in, and we said, what would you do in this scenario? Now you have an EF of 30 to 35%. And you've seen this happen. What would you do? Upgrade him to a BiV, right? That's what we always did. And some people in the US would actually upgrade him to a BiV defibrillator. They do that all the time because patients there don't have to worry about affordability. But you still have to put in a BiV device. It's still more expensive. So what we did here was, we took the old RV lead out, we put a new lead at the his bundle, and we called it a day. This was his bundle-based ECG, and that was his intrinsic QRS overlaid on top. The T-wave changes are because of memory from RV pacing. And this is what happened to his EF. So this is where the AFib ablation was performed. His EF remained down, and then we performed the revision to the his bundle position, and his EF is completely normalized. He's NYHA functional class 1. Okay? So this is a classic example of an adverse event from RV pacing and pacing-induced cardiomyopathy that completely reversed with just revision of a lead to the his bundle location. This was a paper we published. This was a multi-center experience between Dr. Vijay and myself. And we looked at 85 patients that had similar experiences, 79 of which we could easily reposition to the his bundle, even if the patient does not have an underlying escape, which majority of these patients do. If you wait long enough, if you leave them at BBI 30 and wait for a minute or two, you'll start seeing an escape coming through. And you can map the his. If you still don't have an escape come through, you can pace map and find the his. So that's what we did in all these cases. And what you see here is this is pre-RV lead implantation. This is after RV lead implantation. Their QRS gets really wide, and with his bundle pacing, it narrows down. This is their EF at baseline, which really declined down from 54% on average to 34%, and then with his bundle pacing went up to 48%. And this is NYHA functional class improvement after his bundle pacing upgrade. Okay? So this is what you guys can offer to your patients here, because this is all our patients can afford. That's why I think that this is where conduction system pacing can really help our patients here in India. All right, so that was pacing-induced cardiomyopathy. Now talking about what we just touched upon, which is diving into the case we're about to do, left bundle branch block, right? This patient is a classic example, 94 years old. She was my first consultation. 2016, when I first joined Rush as a new EP faculty, she was my first referral for a BiV, okay? And she's 94 years old. She's a non-ischemic cardiomyopathy. Her EF used to be 40 to 45% a few years ago, just like this guy. And her EF has declined now down to 20%. She has a left bundle branch block, and she has NYHA class 3 to 4 symptoms. Now, she's referred to me by a cardiologist for implantation of a BiV ICD at the age of 94, because that's what we do in the US. Okay, so not everything that happens in the US can be translated into our patients here. That is something you have to bear in mind. So the other interesting thing is she walks in to see me for consultation with 3 of her sons, all 3 of whom are physicians. So now suddenly that consultation goes from a 30-minute consultation to a 1 hour, 30-minute consultation. Because my first job was to tell them, I'm not going to give your mother a defibrillator. Okay, and they thought that's what she's going to get. The other issue was she weighed 41 kilos. I could see every one of her ribs. So imagine putting a CRT defibrillator can in someone like that. That can's going to erode. Okay, so this is what we decided to do for her. Dual chamber Hispano pacing. This was her paced ECG with complete normalization of left bundle branch block pattern and a paced QRS of 90 milliseconds. This was her EF at the time of pre-implant, reported at 20%. 3 months post-implant, we repeated another echo. And her EF, after looking at multiple views, was reported at 50 to 55%. She's NYHA functional class 1. She's now 97 and a half years old and is still functional and walks in to see me every year with a cane because of rheumatoid arthritis. So, his bundle pacing for bundle branch block. Again, because we're talking about the evolution of physiological pacing, I just thought this would be a nice one to show. So 1977, this was when Dr. Narula first reported the concept of longitudinal dissociation. What is this? It basically tells us that there are fascicles within the bundle of His that are predestined to become the right bundle branch block and the right bundle branch and the left bundle branch. And disease is often localized within those fascicles. And how did he show that? With multi-electrode catheters, closely spaced multi-electrode endovascular catheters that were placed along the right side of the septum, recording multiple hisses. You pace the proximal poles, you don't narrow the QRS. You pace the distal poles, you narrow the QRS. Because you're distal to a site of disease that is actually within the His. So the disease is often localized within the fascicles that are about to become the right bundle branch or the left bundle branch, and these fascicles are often dissociated from each other within the His bundle. So he first described this in 1977. 1978, El Sharif performed similar work and shows that yes, Narula was right. This happens. Then it was not until 2005 the first case of actual correction was performed with the St. Jude tendril and was published in PACE in 2005. In 2010, Dan Luskarten reported a series of small number of patients in heart rhythm, showing that 9 patients with left bundle and 1 patient with right bundle with a 90% success of narrowing with his bundle pacing. Then in 2013, like I said, Barbara Picardo did some work with the tendril lead and showed that you can narrow left bundle branch block. And not just that, these patients demonstrated improvement in their LVEF and improvement in functional class. But again, a very small cohort of patients, just 9 patients. Now see how this field has evolved. 2015, Dan Luskarten. This was the first randomized controlled trial on his bundle pacing versus bi-V pacing for CRT. In 2015, Dan Luskarten studied 28 patients. Unfortunately, only 12 of those patients completed follow-up, and it was a beautifully designed study. These were patients that all got an LV lead and a HIST lead using a Y adapter. He plugged it into the can, and then each patient acted as their own crossover. So for 6 months, they got bi-V pacing, then 6 months, they got HIST bundle pacing, or vice versa. And he demonstrated that whether you had his bundle pacing or bi-V pacing, both of those cohorts did really well when it came to response rates. In 2017, Agiola did some work in heart rhythm where they looked at, can we actually perform his bundle pacing in lieu of a failed CS lead, and demonstrated that they were successful in doing this in 76% cases. Now you have to realize some of these studies that report success rates of 75 to 80% are not very carefully selected left bundle branch block patients. They include a lot of IVCDs. Santosh showed you a study from Rod Tung where he showed that disease is distal and you may not be able to narrow it. That is patients that have an intact Purkinje activation, suggesting that this is not a true left bundle branch block, suggesting that is an IVCD pattern. It's intramyocardial disease or delay. So in carefully selected cohort of patients, you can get a much higher success rate, but you really need to do that due diligence. So then we did a lot of work. We reported our first series, multi-center experience in 2018. This was 106 patients with 36 patients with left bundle branch block, 12 with non-left bundle branch block, with a 90% success rate, and I'll show you this paper in a moment. We then also reported our experience with His-CRT for patients with a low EF and right bundle branch block. This is a unique cohort of patients. Right bundle branch block will not benefit from CRT, but His-CRT seems to do very well for them, and I'll show you that data as well. And then Dr. Wong published his data again in Heart Journal in 2018, demonstrating a significant improvement in EF and NYHA functional class. And then Arnold did some acute hemodynamic work that was published in JACC in 2018. And then Dr. Vijay Raman published in CircAE on heart CRT. And then there was another study that was published that's called His-Sync that I'll show you as well. So this is really all the data there is ever since. We'll pause, let's see what they're doing in the lab, and we'll come back to this. All right, so this was data on Hispano Pacing for bundle branch block disease, right? So again, in that same Nature Reviews paper, we've listed some of these studies and what these studies studied, which patient cohorts were studied, and what they showed us in the long-term outcomes. So this was the multi-center experience that we published on Hispano Pacing for CRT, where we actually looked at two cohorts of, we divided these patients. This was multiple centers, those patients that underwent His-CRT and were followed up in the long term. We called them either rescue His-CRT or primary His-CRT. Rescue was when you failed BiV pacing and you used His-CRT for rescue therapy, which is what most people would do with the current gold standard being BiV. The other cohort was primary His-CRT because we have had experiences and we know that these patients seem to do better. We would perform Hispano pacing as a primary modality in these patients. So you can see here that amongst all subsets, different subsets of patients for different reasons for CRT, overall the success rate for His-CRT was about 90%. And you see pretty significant narrowing of the QRSs, a significant improvement in LVEF, irrespective of what their baseline EFs were, and a significant improvement in NYHA functional class. The overall response rate to Hispano pacing was 75%, with echocardiographic responses of 73% and super response rate of close to 40%. Now again, like I said, when it comes to patients with a low EF and right bundle branch block, we know that BiV pacing doesn't necessarily work very well. So we decided to study this cohort of patients. So here's an example of a patient with a delayed RV activation. This is the LAD in an RAO projection, the RV, and on the other side, the LV. You can see that after Hispano pacing, the LV activation doesn't change significantly, but the RV activation pretty much normalizes. The other thing you see here is that the earliest activation is on the septum, which tells you that in this patient that we normalize the right bundle branch block pattern. This is likely non-selective Hispano pacing because the septum's activated first. So that's a beautiful example of ECGI imaging. You can see here that this cohort of patients, their EFs improved significantly, and no matter what cohort of patients you looked at, even those patients that had a QRS duration with a right bundle branch block of between 120 and 150 or 180, all of those patients responded equally well with a 70+% response rate, a 76% overall clinical response rate, a 70+% echocardiographic response rate, and a 20% super responder rate. You don't see this sort of response in patients with BiV. And you definitely don't see this sort of response in patients with BiV for patients with right bundle branch block between 120 and 150. Okay? BiV patients that benefit there probably benefit because they also have concomitant left anterior fascicular block or long PRs to begin with. That's where the value gets added. Now there's a lot of talk of His-Sync. So people keep talking about it, saying, oh, it was a negative study, we don't know, what's the point in all this? So I want to clarify some of that. That's the reason I put this in here. So his sync was unfortunately not the best designed study, okay? Credit to Rod Tongue because he wanted to make sure that we can do something like this. We participated in the study, but we participated after the fact that the trial was already designed and it was already on clinicaltrials.gov. So they took all patients with BIV indication, including IVCDs, and randomized them to Hispano Pacing versus BIV. We know it for a fact that IVCDs is not a conduction system disease. It's an intramyocardial process. And so what happened was they permitted crossover. They said if you fail if you're randomized to his CRT and you cannot narrow the QRS, you cross over to BIV. If you're randomized to BIV CRT and you cannot find a good branch, you have to be either posterior or posterolateral. No anterior branches are acceptable. If you cannot find a good branch, you can cross over to his CRT. So you can see here 45% of patients from the his CRT group crossed over to BIV. Unfortunately, 5 of those 21 patients had IVCDs, did not have true left bundle branch block or classic right bundle branch block. And so you're already eliminating 25% of the patients that are not even going to respond to a therapy. That was the fault of the design. And that's the idea of pilot studies, right? This was a pilot study to help us design a larger scale randomized trial without making these errors. But here's the interesting thing. If you look at what happened to the patients on their protocol analysis, the reduction in QRS was much better with his CRT than with BIV CRT. Echocardiographic response rates, more than a 5% improvement in EF. Now, this was a true randomized controlled trial. The echocardiograms were evaluated in a core lab at Duke, and the ECGs were evaluated at a core lab in UCLA, both of which were not participating centers in the trial. So these were blinded analysis. And you see that the echocardiographic response with his CRT was 76%, while it was only 53% with BIV CRT. And the average improvement in EF was 9% with his CRT, while it was only 5% with BIV CRT. Okay, so very preliminary data. Just use this as potential signal that his or conduction system CRT might have a better response rate than BIV CRT, but don't hang your hat on it just yet. So based on all of these studies, current guidelines recommend Hispano pacing or BIV pacing for patients with an EF between 35 to 50% that are anticipated to pace in the ventricle, and also recommend a class 2B indication for dual chamber pacing for level of block at the level of the AV node at the present time. So what are the challenges? There are issues. Why are we talking about left bundle branch pacing? There are challenges. I think his morphology is looking better now than it had. All right, so this was the large-scale study with Dr. Vijayaraman, and you see here that the capture thresholds in general in the his bundle region are higher. The R wave amplitudes are generally lower. The other issue is that these procedures do take slightly longer procedure time and fluoroscopy duration. So it is longer than a regular dual-chamber RV pacemaker. The other issue is when you look at long-term follow-up of the cohort of patients, you see that between 5 to 7% of these patients require lead revisions because of an increase in threshold on the lead. This was very interesting. I like to highlight this for those of you who read these long-term studies. There was one patient in the Hispano Pacing group that developed a pacing-induced cardiomyopathy, while 22% of patients developed that in the RV pacing group. The one patient that developed that in the Hispano Pacing group was a patient that lost Hessian capture. And it was capturing the RV septum alone. So even RV septal capture around the His may not be sufficient to prevent a cardiomyopathy. As soon as we increased the output and they were capturing the His, the cardiomyopathy improved. In the largest series of 332 patients, the lead revision rates were 4.2%. So again, between 4 to 6.7% on the previous study. So here are the challenges with Hispano pacing. Yes, it takes longer. Yes, there may be a failure to implant because of higher thresholds. Disease might be infrahisian, truly infrahisian. You know, depending on your experience level, you might have a 10 to 20% failure rate. That's looking even better. You see that W? That notch is become shorter. That's a good sign. He's headed in the right direction. There may be transient AV block, like we talked about. In 1% cases, there's transient AV block that majority of the time recovers, but then again. And then the evidence, we do not have randomized controlled trials. Everything that I showed you is non-randomized, although large scale, but it's not randomized control. So that then brings us to left bundle branch pacing, and that's a good segue to where we are. So Santosh talked about the anatomy, but I wanted to highlight a couple of things for you guys. So look at this. So this is what the left bundle branch really looks like. Okay, this is a thin cylindrical structure, the his bundle, and the left bundle is a big fan-like structure. Here's another example of how big this structure is before it fans out. You know those illustrations where you see a left anterior fascicle and a left posterior fascicle and it looks nice and pretty? That's not reality. The reality is this. Okay, this is what the left bundle looks like. It's a big stump. It looks like your hand. You know, a big stump, and then all of these fingers that come out that then branch out into Purkinje-like network. So the big stump becomes a better target. That's why you can try multiple spots, and you might be able to get a good result for those cases. So again, like we said, the his bundle is a thin target, while the left bundle branch, which is a big stalk, might have multiple places you can try to fix the lead in and gives you better targets. The first case of this was reported by Dr. Wong in Canadian Journal of Cardiology in 2017. This was his first case. He showed it to us at the first Physiology of Pacing Symposium in Chicago 3 years ago to me and Dr. Vijay, and we weren't sure that we agreed that what he's telling us is real, but then when he showed us the electrograms, we were convinced. So here's what I was trying to highlight earlier. When you think about the conduction system, the AV node becomes the his bundle, that then becomes the right bundle branch. So the right bundle branch goes more superior and anterior on the right side of the septum, in comparison to the left bundle branch stalk that comes off slightly more inferiorly compared to the right bundle branch. Okay, so when you target for getting through the septum while you're doing left bundle branch pacing, you're actually trying to go, you find the distal his, and then you draw a line to the apex, and you go a centimeter or two distal to that, and you're trying to target here. You're not going higher, because when you go higher, you're more likely to ding the right bundle branch and cause complete heart block. So that again is something that Dr. Wong learned early on, saying if you go higher, you're more likely to cause complete AV block. And so he started going lower. Okay, so this is all experience that has taught us these little things. It's not magic. It's not something that we said, okay, we already know how to do this. All these things happen. We learn all these things through experience with perforations, complications, what has happened, and what can we do differently. So the idea being, you go slightly more distal, you burrow through the muscular septum. So you want to look for good R waves. That's why I keep asking, what are the R waves like? You want to look for your starting impedance, because you want to know what the impedance looks like. As you burrow through the septum, the impedance will keep rising, and then it will settle down. So it goes to a peak, and then it starts settling down 100, 150 ohms below where the peak was. That means you're getting closer to the LV endocardium. If your impedance drops by more than 200 or 300 ohms suddenly, like it went in the previous spot he was at, from 650, 700 ohms down to 300 ohms, you're through. I just told him to continue screwing to prove the point that we knew he was through. Okay, because they wanted to try. And again, half a turn more, and they lost capture. Very clear that they were. And that is exactly the kind of scenario I would strongly urge you. Everything else might look good. You might have great capture. Do not leave that lead in, because that lead will dislodge. People think that that lead will not come back, but once you burrowed through and through the muscular septum, you've made a hole. with cardiac contractility, that lead's going to slowly start pulling back and it's going to dislodge. Okay? So that's exactly the kind of situation you do not want to accept as a final result. Okay. So again, like this particular case, in a patient with left bundle branch block, you go, you try to map the distal His and you pace, and you do not see narrowing, and then you try to go more distal, and you can get past an area of disease and result in a nice narrow QRS with the right bundleoid IVCT pattern. This is, let me see if these will play. I guess they're not playing. But the idea was, again, to show you what we're about to see in this case as well, what the RAO and LAO projections look like with septum being flush with contrast. And you're right, you want to be as LAO as possible. I think the issue there was they're also trying to continue to screw in, so you got to find that LAO that works so that you can actually continue to screw the lead in. So the final point is, where do we go from here, right? So this is what our current thought process is. How do we go about this? In the past, we used to accept His bundle pacing capture thresholds of up to 2.5 volts at 1 millisecond. Now we've changed our thinking because we have the option of left bundle branch pacing. I still caution people to jump to left bundle branch pacing. People think it's easy, but I will still caution you with being careful to being too premature to jumping to that for all your cases. We'll talk about this more at dinner because I have something interesting to share with you, but I'm not going to release that just yet. So this is what we do. We start with His bundle pacing. If the His capture threshold is greater than 1.5 or the bundle branch recruitment threshold is more than 2, then we switch to left bundle branch pacing. Or if it's a His lead revision, if a patient has a higher threshold with time, they come back for revision of the lead, then I try to prefer to go more distal on the His or a left bundle branch pacing. If left bundle branch pacing works, then that's great. You accept it. If it fails and the patient has a LVEF more than 50%, you do RV pacing. If left bundle branch pacing fails and the LVEF is less than 50%, you do bi-V pacing. So this is our current strategy when it comes to attempting conduction system pacing. So where do we go from here? We know that His Purkinje conduction system pacing is physiological in the true sense when it comes to ventricular activation. We also know that there's data that's emerging that this prevents heart failure hospitalization, atrial fibrillation, and may possibly affect mortality. We know that it can potentially reverse dyssynchrony and has higher response rates, at least in the preliminary studies that we've seen. With His bundle pacing, we have 2 decades worth of data. We know what the issues are. We know the issues are generally related to a higher capture threshold that may increase over time, and that can impact battery longevity. Oversensing can be a challenge, but we try to overcome that by going more distally. We do not have any large-scale randomized controlled trials, and that's what we need. Left bundle branch pacing is the new kid on the block. It's only 2 years old, and there's very limited experience with it. Like I highlighted at the first part, Santosh was trying to screw the lead in. If you're not careful, you don't go all the way into the V and then pull back, you can entrap the tricuspid valve septal leaflet, and that has been seen. And you may not be able to burrow through, and even if you burrow through, the tricuspid valve septal leaflet is entrapped and you cause TR. Lead dislodgements are more frequent than with His bundle pacing or any other form of pacing because the septum is like cottage cheese. It's like paneer. You get through, you can come out easily too. Okay? Lead perforation into the LV is another issue that we don't look for carefully enough, and it can happen. Yeah, this is my last slide. And finally, with left bundle branch pacing, at least with His bundle pacing, you have data of over 1,000, 1,500 patients, though not randomized, but we have prospective data. With left bundle branch pacing, we have a few hundred patients coming mostly from China at the present time. So unless we have multiple centers across the world that have reported on this, and we know what the potential downsides are, don't jump to this as your primary modality just yet. We need better and dedicated tools for Hispano pacing. We need leads. We need better sheets. And we also need enhanced device algorithms that are specific and can make our life simpler going forward when it comes to conduction system pacing. All right, I'll stop there and let's go to Santosh.